Okay, folks. Well, we are here on Healthcare Unfiltered, the podcast that you should be listening to every week. But today's podcast, I think, is going to have a lot of mix between happiness and sadness. But we're going to use the sadness to bring some happiness because I want to talk about a very difficult subject: palliative care, hospice care, the challenges that we face from all sides when we deal with this. And I couldn't be happier than welcoming Dr. Kuljit Kapur on today's podcast to talk about this. She has a wealth of experience in that area and beyond. So we're going to do a quick introduction and we're going to delve right in. Kuljit, welcome to the Healthcare Unfiltered. I know it's your first time appearing on this podcast. And look, if you play your cards right, you may appear again on Healthcare Unfiltered, and we'll be very honored to have you. But let's just start by getting to know you a little bit. Just tell our viewers and listeners who you are and a little bit of background, and then what happened that you ended up basically involved more in the palliative care and the end of life setting in terms of clinical expertise.
Sure. Thank you so much for having me today, Chadi. I am a board-certified internal medicine, geriatric, palliative care, and hospice physician. Recently received my MBA. My career started in geriatrics, I would say, at 3 years old. My mother used to take, this young, precocious child into the nursing home setting to really spend time with the elderly population. And from there, my influence from my mother, as well as my father, who was a very hard worker and an R&D chemist, came about. I was very comfortable in nursing homes. I always had an inclination toward medicine to really relieve suffering for people, and that was the avenue that I chose. And I went forward and felt that after doing internal medicine, I really wanted to complete that loop and that cycle for the life of a patient. And so I furthered my education by doing geriatric fellowship at Rush University downtown. And then I did hospice and palliative care fellowship combined with Rush, Cook County, and Midwest Hospice at that time, which is now Journey Care. And as I evolved, I worked as a medical director of a nursing facility. I also worked as a medical director of a hospice, and then went larger scale to become a chief medical officer over a hospice and palliative care company. Through that experience, I felt that understanding and being a part of the stakeholders, all stakeholders, and being able to speak for them was important for me to understand the business side of medicine. So I pursued an MBA, and that's where I am right now.
But let's talk a little bit about your decision to pursue palliative care and hospice care, where you obviously progressed, through your career to become chief medical officer. But was there something that led you that you wanted to do this? You wanted to be involved in palliative care, hospice care, or were you influenced by anyone? How did this happen?
So I would say that it's both. I felt there was such a reward in going to those most seriously ill patients and really being able to come up with a regimen and a plan of care that worked for them. I really believe in autonomy, and palliative care is a kind of new and up and coming part of medicine where you're really able to promote symptom management and explore what the goals are for the patients while they're able to make decisions. And that was a big part of it. But the other part of it was that I enjoyed it. I have always been, I always have navigated toward areas of enthusiasm. And I think that we evolve as people and as physicians. And I think that's really important to not, keep our value only in one arena, but to be able to build upon it over time.
Some people might think of palliative care and hospice care, understandably, as a very sad specialty to be at. And were you sad taking care of these patients?
I would have to say, Dr. Naban, that I was in the beginning.
Shadi. What do you mean, Dr. Naban? Nobody on this
podcast
podcast is ever allowed to call me doctor.
Okay. So I really felt in the beginning when I was very close with the patients, I would go out and see the patients as a provider. And that not only made me a good provider, but I got closer to the patients. That's when it was hard. You would come home and you would talk about, how a person passed away, but You learn so much from those patients. Why does the breast cancer patient who has her arm falling off have a better attitude than maybe you or I in life? Going with the flow and saying, I can't go on that vacation, but that's okay, and making a joke out of it. So I've learned so much, but then over time it became less difficult because I realized that this is part of life and we are equipped to help people walk that path. I have so many wonderful stories of how patients really touched me.
Can you share with us one or two of these?
Yes. One story was where I was taking care of a melanoma patient, and melanoma patients may be having a lot of pain or no pain. And I stayed very late at this gentleman's house. He was really struggling with his pain management. And so
So you would go and do house visits?
Yes. That was the beginning of my career. I was a IDG physician. And I would, because I wanted to learn all that I could learn, I went out and saw every patient on my team. And I remember this particular patient, after we were adjusting his medication, gave me a flower from his garden. And it was so symbolic because it was his appreciation. It was the reward of being able to manage that pain. And it was how much need he had that he was feeling so good. And I took that flower and I put it in my daughter's hair that day because she was the last one picked up at the daycare. And what went through my mind that day was, she's okay. She's, well taken care of, brought her home, fed her. She was wonderful. But that man was not okay. And at that moment in time, he needed me. And that is my mission. And that was my purpose, is what I realized at that time.
So when you are taking care of these patients day in and day out, there are two things I'd like you to just reflect on. One, how does it affect your home life? I mean, we're humans, right? I mean, you come back home,
right,
and you probably had 3 patients that died, and are you able to compartmentalize and say, you know what, I'm just gonna be, different person despite what happened at work? Is that easy or difficult on you? And the second thing I'd like you to talk about is, sometimes when you see these patients, you wonder why they haven't really seen you early enough. Why are they so late? And let's start by the first one. How does it really affect your just personal life, if you can?
Yes, I believe that it's important for all physicians to really develop the skills to be able to separate work from home and to compartmentalize. I like that word. I use that word a lot when I'm teaching young fellows or residents, because there's sometimes you have something going on either in personal or you have something going on in professional, and you have to divide it so that you're able to do your best where you are. So over the years, and after probably 5 years of doing palliative care and hospice in different settings, I became stronger. And I think that, I started realizing that it's not a sad thing that happened. It's a beautiful thing that happened. I was able to provide and help provide with our staff. It's not only me, it's always the team, provide dignity to this person. And so that leaves me with a feeling of calm, which is good. So the second part of your question is, I think that over time we realized, and I've realized in palliative care, that we have to bring people on palliative care sooner than later, because it's an educational process. It's a process of understanding who that person is. It's a process of creating a relationship. And the sad part is, if we don't do that, then they're not ready to go on to the comfort-focused programs like hospice at the right time. And that's okay. In most places that I've worked, we are still able to take care of that patient on palliative care. However, it depends, where they're at in their understanding.
But the thing is, once you tell patients that you're going to refer them to palliative care, they assume that you're just giving up on them, that there's really no more care. Right. You just, so from a, if you're an internist, oncologist, cardiologist, and the minute you mention to a patient palliative care, from a patient perspective, they're going to think you threw in the towel.
Sure. And that is a problem, because it's the nomenclature, it's the semantics. We have to do a good job, a better job as specialists as well as providers to explain the difference between palliative care and hospice. Palliative care is symptom management. Palliative care is supportive care. It doesn't mean that it needs to go into the direction of hospice. I may just be managing their pain and they're going to be fine after their stem cell transplant. So this is just kind of changing it a little bit to a supportive care ideology, that this person is part of the team and they're going to be here to manage any symptoms that you have that come about. They're going to be here to create a rapport with you, to support you psychosocially, because this is very hard what you're going through. This is the whole idea. The whole idea of palliative care is really the care coordination being the center and keeping the services that help and getting rid of the services that are not helpful based on the prognosis of the patient.
Have you had scenarios where by the time you saw a patient for palliative care consults, you're like, oh my gosh, I can't believe I wasn't called early enough. Like, I mean,
Oh, yes.
Why haven't they even
Yes.
called me?
Right.
Can you share an example?
And I
or
will
two?
tell you, I have a great example. I was, trick-or-treating with my children this past year. And, as a hospice and palliative care physician, you're always on call. You never know, just like birth, you never know when somebody's going to die or need you. So I was on the phone with a family member, and this is a patient that had rectal cancer. They had gotten, he was really advancing with pain, and pain advancing means disease is advancing. That's like a board question. And so I knew in the back of my mind, he's not doing well. He's probably not going to bounce back from this. Let's bump up the medications. There's probably an anxiety component. But she said, Doc, I want a second opinion. And I said, well, you're always welcome to a second opinion. However, let's control the pain right now, okay? I think someone underdosed him. Let's double it. Call me in a half an hour. Let's talk in a half an hour. And then when you know how to do this, it's all about follow-up. So what happened is the patient was very well controlled with pain, and I received a call that he died the next day. And I had mixed feelings because I felt, he did not die with pain. And I'm so glad that I was called during trick-or-treating. However, I felt bad that he wasn't referred early enough to understand where he was with his disease. That whole process of palliation, starting at the beginning of the diagnosis, is necessary. And that is why we have statistics of 9 days to death in this country of when somebody goes on hospice. So I feel like we should be able to do better in this country with our quality of death score, and also bringing patients onto palliative care earlier.
So when you say 9 days to death, is that too short?
Yes.
So
yes.
what's an acceptable
the
time?
hospice
What's an acceptable metric?
I feel that we should be bringing patients on 1 to 2 years in advance of their death to palliative care. And hospice is a benefit. Then we shift patients to when their estimated life expectancy becomes 6 months or less. And those are dictated not only by Medicare criteria with Palmetto, but this is somewhat subjective too. The longer you have done this, when there are certain criteria that the patient is meeting that they qualify. And it's always very sad they don't take advantage of that, because it's really a free benefit with Medicare Part A, where everything is covered from the medications to the diapers to the services that are provided in the home.
So if I'm hearing you correctly, that palliative care should be involved within 1 to 2 years of the end of life. I just have to tell you, I'm not really sure doctors are good in predicting how well or bad patients will do. So it's a little bit arbitrary, right? I mean, how many times have we been wrong where we thought somebody's going to die sooner and they died later, and vice versa? I feel we put ourselves occasionally on a pedestal and saying like we know it all, but I don't know. What are your thoughts there?
There was one time a physician, and remember, the longer you know a patient, you're going to overprognosticate that patient by 6 months. And so I remember a physician telling me, no way, this patient's not going to pass away. He knew the patient longer than I. But I'm coming in as a consultant, and I said, doctor, with all due respect, this patient is not well. We're giving this patient, when you start seeing the benefit and the burden going back and forth when you're giving a medication and then they're bleeding, and then, you stop that medication, they're not bleeding, that's the time the goals of care conversation needs to start, and the palliative care should start. The prognosis is becoming worse, the weight's going down. There's many different criteria we use. However, in this situation, he said, absolutely not. I said, okay, I just kind of agreed to disagree. And that patient died within 4 months. without the services that the patient could have had, and it's always a sad situation. So my job as a specialist is really to educate.
Yeah.
Okay.
Well, I'm glad we switched the servers because, we got to make sure we get the best ability to capture the voice and the visual as well. So for listeners and viewers, you may have had some issues listening, but we fixed everything. At least that's what Dr. Kapur promised us that she did. But I want to go back. You mentioned a couple of things that it is 9 days to death is what the average is in this country. What is the proper time? And you mentioned 6 months, and I have no idea how we predict 6 months. But B, how do we compare to other countries? Like when you say 9 days, I'm thinking, well, I don't know, that seems good to me. But what's how do we decide what's good or bad? And how do we compare to, I don't know, Europe, India, China, Middle East?
Sure. I've actually looked at this. The quality of death index is really, the idea of, how that process goes, and other countries have been higher. England, for example, is very high on the quality of death index. In fact, United States is probably, second tier in that way. And so we have a lot of work to do. But I think when it comes to predicting the end of life, we have certain criteria, which are Medicare criteria. Also, they're called LCDs. And these criteria we have to meet in order for the patient to qualify in this country, at least for hospice. It's a little bit different in America because we are very good about giving autonomy to patients. In other countries, the doctor will come and say, you know what, it's time for hospice, we're putting you on hospice, right? So they maybe don't give the choice, but they have that grip and that relationship with the patient, and the patient trust the physicians that when they say that, that's what needs to happen.
But there's a lot of these cultural barriers are real. I think it's very difficult for anyone to be facing their own mortality,
It very much is. And I think that it's very different within different ethnic groups. I would say, I am first generation Indian, and, it was kind of a joke. I asked my dad, what he would want in the situation where there would be no meaningful chance of survival. And he said, Kuljit, I'm not there yet. Let's not talk about it. So there's a cultural component. And then if you go into the African American population or the Hispanic population, it is a little bit of a distrust of the healthcare system. If you do tell them, and maybe the prognosis, they have been not treated fairly in different situations. So they don't trust that what you're telling them is true. So that is a barrier. So it takes many conversations.
So, you mentioned families. That's really interesting because I think dealing with the patient is one thing on clinical grounds and medical grounds. Then you've got the family. And the family sometimes wants you to do more than what you could do. There's a lot of dynamics there. Yes. And there are times where they say, I want IV fluids, I want G-tube to get nutrition, I want X, Y, and Z. Tell me about, as a palliative care physician and a hospice physician, how do you deal with the family dynamics when you sense that what they want from you is something that is more than what you should be doing?
Yes, I will tell you that that's a process in learning how to deal with families and these situations. I will humbly say I'm very good at it at this point, 10 plus years beyond in the career. But the first time I tried to do it as a physician, I was fired off of the case.
Yeah.
And,
great.
They said, you're trying to kill my family member. And I said, no, I'm not. You're turning down the IV fluids, and you're turning things off. But they didn't understand that you're going to drown in those fluids. So, gotten better with people skills over time, and also gauging your audience. And so this has to be a process in some cases. You can't bring up hospice. You can't bring up different, modalities very quickly. So transfusions, blood draws, do not hospitalize. These are IV fluids, G-tube. We give them the statistics. Okay, so in a dementia patient, the chance if you come to 6 months or less estimated survival of you coming out of a resuscitative effort is 1% or less. So we give them the statistics and then we let them make the decision. We show them on YouTube what a CPR looks like, okay, how aggressive it is, and if it would really benefit. We go back to what the goals of the patient really would be. Sometimes the power of attorneys think they make the decisions. They don't. They're just acting on the behalf of their parent. I have been there. We have acted on the behalf of my mother when she was on event. And we said, whoa, she would kill us if we continued on like this, right? You have to know, your parent, you have to pick your power of attorneys wisely. So we bring up all of that as discussion. The last thing I'll mention is in extubation to comfort measures, I take the approach of we don't have to turn it off or pull it out, okay? I take the approach of, let's just not turn up the settings if something were to happen. Okay, let's leave everything where it is. Your family member is not doing well. Likely this is going to go down. Let's get the do not resuscitate in place, and we just will not turn things up. They are going to pass away anyways. So it makes it easier for the survivors that way, and I think that's been successful.
Do you think, Kuljit, that trainees like residents, students, fellows get enough exposure where by the time they are finishing their training, if they don't do advanced fellowship, do you think they are getting enough education how to manage A, the communication piece, and B, the management piece?
I do not believe so. I think that it is now becoming a little bit more mainstream to involve palliative care in rotations and geriatrics. But really, I feel like it should be more of a formal rotation that is required, because not only do you learn communication, people skills, symptom management, I would consider myself a pain specialist, and also just learning how to navigate prognosis by looking at different signs with the patient.
Yeah. I mean, I agree with you. I think we should really train people how to manage pain a little bit better. But I also feel that there's this barrier where I've encountered with some of my patients where occasionally they worry, they don't want to tell you how much pain they have in.
Yes.
And let's face it, what happened, and this is not about opioid epidemic, but there has been a lot of data that we overtreated pain also, right? I mean that
Sure.
There were situations where patients became addicted because of our pain management. And obviously this doesn't apply at the end of care, but from a patient perspective, they worry. I mean, I have had patients who have very limited life expectancy telling me I'm worried about getting addicted.
Sure. And what I say in response to that, because I get that a lot, is that your physiologic, well, we don't use the word physiologic or pathologic, I kind of break it down a little bit further. Your ability to get, addicted is very low when you have real pain from a physiologic standpoint. And, if there has been addiction in the past, you need to give higher doses. But I think the point is we have to get down to the psychosomatic component of pain, which I think that we do not identify readily. And that is why the opioid crisis happened, is because I think that people were treating their anxiety with narcotics. Yeah. And I think that this is a multifactorial approach we really need to be taking to the patient. And palliative care is exactly that.
So I want to talk a little about the team. So the palliative care team and the hospice team, you obviously did both, but are there differences? Like, you were the physician on the team. Who else do you have on your team, and how they are different in the palliative care team versus the hospice care team?
Sure. It's just in general. So palliative care will have a physician. It will have the advanced practice mid-levels. And there is often a social worker and ancillary support from a case manager or an LPN who's doing kind of the orders in the background. That's at least the way it was in the recent company I've worked. And the coverage for palliative care is just like if you go to a cardiologist, okay? It's Medicare Part B. Now, the services provided with that are limited. So what we do is we use home health in the community to see the patient with us, who home health is covered by Medicare Part A. So you're getting the best for the patient, but the idea is you have to communicate. That's where things can go wrong. One person is doing one thing, other person is doing another thing, and we really have to work together. Now, in contrast, hospice is covered by Medicare Part A. Either you have hospice, you have home health, or you have post-acute care, which is like when people come out of the hospital and go into a nursing home. That's what you can do for Medicare Part A. When somebody goes from palliative care into hospice, they get rid of the home health and the hospice then takes over. You have a social worker, a chaplain, nurses that will see the patient 2 to 3 times per week, and you will have your different levels of care as well. Okay, so there's routine care. Most people are on routine care that's reimbursed at a different rate. You have your continuous care. If I had an unmanaged symptom, I could send somebody into their home 24 to 48 hours to manage that symptom with callbacks to me so that I could get it managed. General inpatient level of care, different reimbursement. That's typically in a standalone unit or in a nursing home. And then there's also respite. Say the caregiver needs a break. I had a dementia patient once, and there was a son that was taking care of his mother, and he needed a little bit of a break. And I suggested respite, and he went, and you can do that up to 5 days. It doesn't have to be full 5 days, but the hospice covers it. So this is fully covered medications. You can still see your doctor. We do not get rid of all of the medications. Everybody says, okay, they're going to take everything away.
Yeah, but the team for hospice, do you have a psychologist, for example? Is a psychiatrist involved? Is there somebody who addresses psychological
The social worker.
A social worker.
Yes.
Okay.
And then there's a chaplain.
So I want to pivot into the business aspect. I think you already started alluding to it, but I want to try to explain to viewers and listeners a little bit in terms of the coverage in that piece. And I believe you delved into the business aspects when you went back to school and get an MBA. What led you to decide to get an MBA?
So first of all, I'm just really ambitious, which I need to stop that. but I do feel, I really enjoy the business side of medicine. I think I have a lot to bring to the table in different arenas of business. And I think it's really nice for doctors to have a seat at the table with the people making the decisions about the patients that we take care of. We have to have that voice, and that's the main reason I did it.
Got it. Okay, so I really want folks to understand the insurance piece. We're going to start with Medicare and Medicaid government payments for palliative care and for hospice care.
Okay.
So, and then we'll go to commercial payers. But for palliative care, is this considered like any other consult? So say I'm an oncologist, I'm seeing a patient, I want to send this patient to a kidney specialist. Is it the same?
At this point in time, it is. Now, that can be a very complex question because now we're moving into value-based medicine. But yes, Medicare Part B will cover a palliative care consultation just like any other specialist.
Okay. And then obviously in palliative care, you have additional medications that you may want to prescribe. Let's say some of them are IV, some of them are oral, like the standard, as if I am just doing everything. Sure. The only thing I was going to ask you, I mean, obviously, sometimes our treatments are, in cancer, we may want to give radiation therapy that might alleviate the pain for somebody.
Yes.
And they have limited life expectancy. And my understanding is some hospices allow that, some hospices don't.
That's correct. And I will say I've worked at both. Larger companies have the bandwidth and the finances to be able to support that, but with a wean plan. And smaller companies just say, look, keep them on palliative care. We'll shift them when they're done.
Okay. So now for the hospice piece, hospice is completely covered by Medicare, like patients do not pay anything?
Yes. So it all comes down to what the terminal diagnosis is. And that's very important to understand because if you have a patient, for example, who has breast cancer, but they have an unrelated myelodysplastic disorder, this has happened, they can continue to get the transfusions that they were getting for the myelodysplastic syndrome. And I've had people sent home from their oncologist and they said, you're on hospice now. And I sent them right back. I said, the coverage for the terminal prognosis, all the meds are covered, everything is covered, but the other part of Medicare is going to still cover anything unrelated to the terminal diagnosis. So I said, you can do that, but when you get too weak and now you're passing from the breast cancer progression, then it doesn't make sense for you to go get those transfusions, right? I may authorize one if it makes you feel good. A hospice will pay for it because it's all about comfort, not the lifeline at that point.
But the Medicare is covering all of this based on the terminal diagnosis that you mentioned. Yes. And when you say if you decide to do something out of the norm that Medicare does not cover, then the hospice company or the hospice hospital, wherever, they cover that out of their own budget.
Yes, they do, because there's a per diem based on the level of the care, right? Routine level of care, continuous care. You get money every day for taking care of that patient. And so within that amount of money you get, you have to pay for the services they receive as well.
And then, obviously what you mentioned is that the average is 9 days to death. So I presume Medicare is okay with that. Obviously they want it longer, but the question is, has it been a situation where somebody was in hospice and then got out of hospice because they did better than they thought they were going to do?
Yes, and I've had many examples like that. I've had some prostate cancer patients, for example, that I'm like, you are not sick enough for me anymore, sir. And so
that's a great news.
That's a good news. You graduated. So there's been other situations where, for example, in congestive heart failure, I had 2 children while one lady was still on hospice. I said, lady, no, I didn't say lady. I said, you don't qualify anymore because you still meet soft criteria. However, you're not showing progression at this point in time. We're going to put you on the palliative care program.
Okay. How about public aid and Medicaid? Folks who are on public aid, is it also covered?
Yes. And that's the beautiful thing, is our country does take care of the patients who need help. I have trained with the poorest of the poor and the richest of the rich, Cook County, Rush. Okay. So I've also helped with like undocumented, patients, mail order brides. I've really been able to see how we can help navigate the system to make sure that patients in our country are taken care of. Sometimes people don't have coverage, but those are sometimes, I don't know, the patients I give the most attention, because it's just sad that the situation that they're in, and whatever I can do within the boundaries of the company that I am, even if it's a free service, we can still be creative in taking care of people.
How about commercial payers? Because these are very different, right? I mean, they may have different criteria. What has been your experience and observation for commercial payers?
Commercial payers have been not an issue. Most commercial payers will cover hospice benefit if the physician states that they meet eligibility.
Okay. Do you want to just tell us a little about the eligibility? I mean, I think a lot of us probably, they know the eligibility, but not necessarily in a systematic manner.
Sure. So every disease that we bring a patient on for hospice has different criteria that you need to meet to say that they're terminal, estimated at 6 months or less, if the disease runs its normal course. Now, for example, with a dementia, you need to have seen at least 10% weight loss within 6 months or 5% in 3 months. You have to have had, for example, with Alzheimer's, the patient needed to have a very serious infection or a sacral pressure ulcer or something showing the catabolism. The other piece of that,
not all of these, like one of them, like people have to have one of them or all of these.
Typically, they will need to have all of them. And so the other piece with Alzheimer's, for example, is they need to meet a FAST criteria of 7C. That means that cognitively, they've reached a point where the cognition is affecting their movement, brain movement, that they are not able to walk anymore. And so that those are specific scales. We use the ECOG scale for functional status 2. Function guides prognosis, and so does disease symptom burden.
Okay. So in terms of, from a business perspective, from a payer perspective, from a cost on a patient perspective, all of this is covered, including a respite care, which you mentioned, which is really very interesting. Are there any additional coverage for post-death bereavement services or even funeral services, even burial services?
Yes, and not for funeral. However, I have seen some creative situations with funds that can be, charity that's been given to the hospice where they help pay. I've had owners at other companies that have just paid for the funeral out of their pocket. That was the company before my last company, which I thought was beautiful. Each company that I've worked at had different beautiful resources that they've been so wonderful with their patients. However, the bereavement is when you're with a hospice company, it's always covered for 13 months after the patient passes.
How many hospices are out there? Let's talk about Illinois. I mean, I don't know, like I'm just curious as to, I'm just trying to think of I mean, how many people die a day in the state of Illinois, for example? How many hospitals? Like, I don't know, like I obviously, when I was seeing patients, I had like 2 or 3 hospitals I basically worked with mainly, but I have no idea how many hospitals are out there.
There are hundreds, and I will tell you
in the state, in just like one state, we're talking just state of Illinois.
Yes, and I will tell you, some are bigger, some are smaller, and I can give you an example. You know, with a census of about 800 people in, for example, and in Illinois maybe 600 people, I would be signing about 5 to 10 death certificates a day for that type of census. There's a portal in Illinois. I'd be signing them all. Yeah.
So all of these hospitals are busy. Like, I mean, I guess in your experience, why would a physician or a family utilize one hospice services versus another?
Really, it's a choice. Different networks have preferred providers. It's the quality of the care. It's the nursing staff. It's the management. There's many different reasons. However, I think, there is a way that you can check the quality of hospice companies online, Medicare.gov. And I think that there are certain quality metrics that, I think at baseline should be met before you select a company.
I have to tell you, Kuljit, I had no idea there are hundreds of hospices. I thought tens, to be honest. I mean, I thought tens, but hundreds of hospices in one state. And these are, I mean, are there some hospitals are national, like they have branches all over the country?
Yes, there are. Accent Care, and now what we're seeing, that's an example. Now what we're seeing is that a bigger hospice is absorbing a smaller hospice. That's the way healthcare is going, as we see also with accountable care organizations taking over smaller entities. And that's why now value-based medicine and being reimbursed differently is really where we're at in healthcare. We're being reimbursed for quality over quantity now.
This is fascinating to me. I mean, this is like learning about all of this is fascinating. There's like a human element of this. There's also the teaching element of this. And there's also the financial reimbursement / business element of this. So what's next for you? What are you staying in that arena in terms of, I know you said you've done this, you became a chief medical officer and you got your MBA. Are you staying in that field? Are you thinking of branching out? What do you think you're going to do?
Yeah, so I think as we evolve as human beings, I think that our enthusiasm is going to differ for different areas of medicine. I think I chose right. I did internal medicine, which covers everything. So I have that choice to really pivot into a different arena and really explore. I've tried out the business side and the hospice and palliative care. And the next step would be to work in a post-acute care setting and really try, to promote the growth and at an executive level in a post-acute setting. I think that my feel is that my ability to make an impact is not kind of in one area of medicine. And I think in order to, do that, we have to find what energizes us. We have to find what, fills our cup. And at this point in time, I've also branched into medical cosmetics as well as artificial intelligence, working with a wonderful gentleman in downtown Naperville with Harder Investments. And I am able to really learn about medical cosmetics and other ways of promoting quality of life and well-being with patients. The other piece to that is
going completely opposite, from hospice care to cosmetics.
It helps with the skin, that's the beauty of it. And then also, I'm so excited by it because it's just very different than what I've done for 10 years. Also, with Harder Investments, I'm working on promoting and championing a product called First Look Intubation. And this is with Guidance Airway. And it's an intubation device that has been developed, and it will, by Bluetooth technology, go into the right space and even, spray, the lidocaine that's needed. So this is just such a up and coming, area that I've even learned about in MBA school. I've read so many articles on artificial intelligence, technology, accounting. I'm like, let's use it, So pivoting a little bit is a good thing.
I think Chat GPT is going to control our lives. That's it.
I just read about that. I was like, wow, I just wrote that person's paper.
Yeah, I need to utilize it more. Kuljit, this was really a lot of fun. Anything I should have covered or asked you about hospice, palliative care, and the impact of that I completely overlooked and I did not, that you think is beneficial to listeners and viewers to understand and know?
I think that you did a great job with asking all the questions. We covered a lot. I think on the surface level, people just need to understand there is a difference between palliative care and hospice. And I think, the way of the business side is always going to change, but we always, whatever we do, need to keep the patient at the center. So I think we covered it well.
I do like how you mentioned earlier, though, if we just change the nomenclature from palliative care to supportive care in certain scenarios. I mean, we give when I prescribe something for nausea and vomiting before chemotherapy, that is palliative care. I am palliating the symptom of nausea and vomiting for that patient, right? I mean, I give chemotherapy for pain for somebody who has cancer that's causing pain, although they may have like 2 years to live, but the chemotherapy is also palliating the symptoms.
You bring up such a good point. Every good internist and doctor will practice palliative care. And how I explain it is palliative care is specialized internal medicine and hospice is specialized palliative care. You get more specialized toward the end of life.
Well, thank you so much, Dr. Kuljit Kapur, on the Healthcare Unfiltered podcast. I hope we have you again, and we're going to learn more next time I have you on. We're going to talk about your career in medical cosmetics.
Okay, thank you very much for having me.